Alright class, let's continue our discussion on the blood. Our next formed element that we're going to be talking about is the blood platelet, aka the thrombocyte. Now if we look at platelets themselves, they actually, for lack of a better term, sometimes it's kind of difficult to call a platelet a cell. A better term for a platelet is that it's a cell fragment. And it's a fragment of what? It's a fragment of a really big cell that's kind of sloughed it off. This really big cell that sloughed off the platelets is called a megakaryocyte. If we look at this term, mega meaning big, and karyocyte meaning it's a cell that has something. I'm actually not sure what karyo means. I should look that up. My bad. Now, these megakaryocytes are present in the red bone marrow. Our red bone marrow is the tissue type that makes all of our blood cells. And in terms of the numbers of platelets that we go through about 200 billion platelets per day. To put that in perspective, you go through 1 trillion platelets per work week. And what do we do with these platelets? We use them for blood clotting. We use them to aid us and protect us from losing too much blood. Now, within our blood, there's going to be some proteins dissolved, some of which are going to be thrombin and fibrinogen. Both thrombin and fibrinogen work together with each other to make a clot by forming a mesh of fibrin fibers. And that mesh is then going to catch the red blood cells and form the scab, or the clot, so to speak. So let's look at this process of blood clotting. First, step number 1, we're going to puncture a blood vessel. And after we puncture that blood vessel, platelets are going to stick to the punctured portion of the blood vessel. There are special chemical signals that are released, and in particular, when platelets are exposed to collagen fibers, they start to aggregate or accumulate or congregate on each other. After the platelets stick to the damaged spot, there's going to be a chemical cascade initiated, and that chemical cascade is very briefly shown right here, and this is only a snippet, a segment of that chemical cascade. What happens? We are going to use some activating chemicals in addition to calcium ions to take prothrombin from an inactivated form and turn it to thrombin in the activated form. Once we turn thrombin on, so to speak, that thrombin, using more calcium ions, will take deactivated or unactivated, I should say, fibrinogen proteins and activate them to become fibrin proteins that can then form fibrin threads. And those fibrin threads form, as we can see here in this electron micrograph, we can see a meshwork of fibers holding the red blood cells in place. That meshwork is made of fibrin fibers. And this is the clot. Now, there's some disorders that involve the thrombocytes, the platelets. One is thrombocytopenia. As the prefix here shows us, thrombo tells us that's related to the thrombocytes or the platelets, and penia means that there's a deficiency of or not enough of. So thrombocytopenia is when we do not have enough platelets in our bodies. Generally speaking, this is because the bone marrow is not pumping out enough platelets, or there's been some kind of breakdown of the platelets outside of the bone marrow. So why would we not have enough platelets? Maybe we don't make enough, or maybe we're destroying them too quickly. There's two possible causes here of thrombocytopenia: not low production or high destruction. We also have thromboembolism. A thromboembolism many times is just going to be referred to as an embolism. What is an embolism? An embolism is a blood clot that has moved around and gotten lodged somewhere in the human body, other than where it started. So a thrombocytopenia specifically is a blood clot that is formed from platelets. This is going to be the overwhelming vast majority of blood clots. It is hypothetically possible to have a blood clot form from some other mechanisms. For example, you could inject starch into the bloodstream, or you could have an inappropriate blood transfusion, or some other mechanism. But the vast majority of emboli are going to be from platelets accumulating with each other, and that they will be categorized as a thromboembolism. And then finally, we have hemophilia. Hemophilia is a disorder that starts, or it results when some of those proteins, some of those chemicals in the chemical cascade of blood clotting don't work appropriately. So if somebody has hemophilia, they are not able to blood clot very quickly. They can't form that blood clot quickly like a normal healthy person was, and instead it takes them a very long time to form a blood clot. Thankfully, there's two separate chemical cascades involved for blood clotting, so if one's not working very well, we could potentially use the other one to blood clot. The reason this is called hemophilia, hemo is a prefix meaning blood, philia meaning to love, brotherly love in this context, or non-sexual love in this context. So hemophilia literally means blood, or blood love, or the love of blood. Someone who has hemophilia loves their blood because they keep losing so much of it. They really have a strong attachment and want to keep the blood that they do have, or at least that's the idea behind the name. So, class, concept check. Which mineral is needed to activate the blood clotting cascade? Is it magnesium, sodium, calcium, iron, or zinc? Go ahead and rewind the video, get me an answer, or you can pause it and check your notes or textbook. 5, 4, 3, 2, 1. The correct answer is C, calcium. You can see that, there's some calcium 2 positive ions being used for here and here to go from prothrombin to thrombin and from fibrinogen to fibrin. So we need calcium to activate the blood clotting cascade, in addition to other things. So let's talk about blood typing and blood transfusion. First of all, what do you need to know about donating blood? First of all, donating blood is safe and sterile. There's a lot of training that goes into the individuals that collect the blood during blood donation processes, and most times you're going to donate about a pint of blood. Every now and again, if you have in-demand blood, like O negative or A positive blood types, you might be asked to double dip or give a double dose of blood. Individuals that donate blood, generally speaking, are going to replace the lost fluid in their bloodstream, the plasma, in just a few hours, and it'll take them a few weeks to replace the cells. And as a plus, this process of replacing the cells requires calories. So I like to think of donating blood as the easiest workout you're ever going to do. You just sit there and your body loses calories in the process. And then usually most people gain all those calories right back by overindulging on the cookies and juice that are offered afterwards. But that's a whole separate matter. Sometimes after you donate blood, you're going to feel dizzy or sick. And that's typically because you have lowered blood volume, lowered blood pressure, and lower blood oxygen levels. And that's one of the main reasons why you're told to sit down and eat a snack. Not that most people really need to be forced to sit down, take it easy, and eat some yummy treats. I mean, talk about torture, right? Now, after you donate blood, your blood is going to be tested for syphilis, HIV, antibodies, and hepatitis, among many other things. And if your blood is tested for some potentially negative things, and it comes back positive, the test comes back positive, several things are going to happen. First, your blood is disposed of in a sterile method. Generally speaking, it's going to be autoclaved and then incinerated or destroyed with strong chemicals. And another thing is that you, as the person who donated the blood, are going to be notified, hey, by the way, we found this really bad thing in your blood. You might want to know about it. And if you are worried about your blood not being used, that's okay. I need to let you know that your one donation of blood can save many people's lives. That one blood donation can be separated. We can separate the plasma from the red blood cells, from the platelets, so one blood donation can save 3 people's lives. Now, generally speaking, if you have any of these risk factors, among other things, you should not give blood. And if you go to give blood, there's a long questionnaire that you take before you donate the blood. The reason that people are pre-screened out before they give blood is because we want to keep this process cost efficient. If you are at high risk of having blood that needs to be rejected or destroyed, we want to save money and save time by not collecting the risky blood. I know for me personally, when I was in high school, I took Accutane, which is an acne medication, and I took that medication because, well, I had really, really bad acne when I was in high school, which is a whole nother story. But I digress. I had really, really bad acne, took this really strong medication, and that strong medication messes with individuals' blood protein counts. Or I believe it was a year or 2 years after I finished taking Accutane, I could not donate blood. If you lived in Great Britain when there was that mad cow disease outbreak in the late 1980s, you are banned from donating blood for the rest of your life. We just don't want to collect it because it's too risky. Some other things that are risk factors that are going to make it so that you cannot donate blood include if you've ever had hepatitis or malaria, if you've been treated for syphilis or gonorrhea in the past 12 months, or if you're at risk of having HIV or have contracted AIDS. You should not donate blood. We do not want it. It's too risky, and it's not cost effective to collect that risky blood. There's some terminology that can help you understand the blood typing that occurs while you're donating blood and while someone's receiving that blood donation. One is antigen. An antigen is any substance that does not belong in the body, and it's going to be able to stimulate an immune response all by itself. In almost every situation, these antigens are going to be a complex carbohydrate, aka a polysaccharide, or a protein, sometimes referred to as a polypeptide. Antigens are usually going to have, after they stimulate the immune response, are going to have something that our body makes to stick to them. And that thing that our body makes to stick to them is called an antibody. Antibodies stick to specific antigens. An antibody is a protein that we make in response to the antigen being in our body. What does the antibody do? The antibody binds to the antigen, and it's like a flashing neon sign on top of the antigen that highlights that for destruction. During blood transfusions, we're going to take blood from one person, patient A, and give it to the other person, patient B. And during blood transfusions, it's very important that we understand the blood types and know, bless me, know the blood type of the person who's donating and the blood type of the person who is receiving, so that we can avoid DIC, disseminated intravascular coagulation, which is a nice way of saying that we want to avoid having blood clots form spontaneously all over the recipient's body. It's a terrible way to die. So what determines your blood type? We have type A, type B, type AB, or type O. There are two primary blood antigens, type A and type B antigens. These antigens exhibit what is known as codominance, for those of you who like Mendelian genetics. If somebody has type A blood only, they are going to have antibodies for type B in their bloodstream. If they have only type B blood, they'll have antibodies for type A. And if they have type AB blood, they won't have any antibodies for A or B. And if they have type O blood, they are lacking the antigen, the A antigen, and they're lacking the B antigen. So they are going to have antibodies that will attack either A or B or AB blood. Generally speaking, we as individuals only will have antibodies that will attack antigens that are not present on our blood cells. So if I have all the antigens on my blood cell, I won't have any of the antibodies. If I have none of the antigens on my blood cell, I'll have all of the antibodies. So here's someone in this figure that has type A blood. How do I know they have type A blood? They have the A antigen on their red blood cells. And if they have that A antigen on the red blood cell, they absolutely do not want to have any A antibodies, because then their antibodies would destroy their own blood cells. So they don't have any A antibodies, but they do have B antibodies. And these B antibodies don't stick to their A antigen, so the patient is fine, they're all dandy. And as long as we never give them a blood donation with B antigens that can stick to their B antibodies, they will be just fine. How can we remember what each blood type means? Generally speaking, blood types are going to be named after the protein antigens that are present on the surface, except for type O. Type O means that you do not have either the A or the B antigen. So type O is the lack of the A or B antigen. It's based off a German word, own, and I'm positive I'm mispronouncing it. I'm terrible at German, other than saying nein. I'm pretty good at saying no in German. It's based off a German word that means without or lacking. And that German word just happens to start with the O, letter O. And type O blood is lacking A and B antigens. Now, our blood types are going to have antibodies for antigens that we do not have on the surface of our own red blood cells. That's a nice way of saying that we will not make antibodies that attack our own blood, but we can make antibodies that may potentially attack someone else's blood. Maybe, depending on what blood type they have. So if someone has type A blood, they'll have the type A proteins on the surface of their blood cells and have type B antibodies in their blood. Like in this figure right here, type A proteins on this type A blood combined with type B antibodies that do not interact with each other directly. So if someone has type AB blood, what can we say about them? Well, we can say that they'd have the type A antigen and they would have the type B antigen on their blood cells. Now, in terms of antibodies, if someone had type AB blood, they would have no A antibodies, and they would also have no B antibodies. They would be lacking those antibodies. So here we go. Someone who has type A blood has B antibodies. Someone with type B blood has A antibodies. Someone with AB blood has no antibodies. And someone with O blood has both antibodies. So if I was receiving blood from a type O patient, that type O patient doesn't have any A or B antigens on the surface of the red blood cells. So theoretically, there would be nothing for any antibodies that I potentially have to stick to. And this is why type O blood, particularly type O negative blood, we haven't talked about the rhesus factor yet, but type O negative blood is considered the universal donor. On the flip side, if you have A and B antigens on your blood cells, you don't make any antigens that can stick to either the A or the B antigen. So if you have AB blood, you don't make those antibodies that will attack blood cells. And particularly if you have AB positive blood, you are considered the universal recipient. So, students, I want you to ask yourself, how altruistic are you, or how selfish are you? Would you be selfish and prefer to have AB positive blood and be a universal recipient and always be able to receive a blood donation? Or are you more altruistic and would you rather have O negative blood and be able to donate blood to anybody? How can we determine if blood types are compatible for a blood transfusion? First, we need to be able to figure out what the donor's blood cell or blood type is. So we need to type their blood. And then we also need to consider what kind of blood the patient has. So the patients can only receive blood that they do not have antibodies. If they do not have antibodies in their own bloodstream that will attack the blood that they are receiving. If they do have antibodies if the recipient has antibodies in their bloodstream that will attack or recognize antigens on the donated red blood cells, then that blood will clump or clot. It will agglutinate and cause massive clumping or clotting all over the body, and generally speaking, kill the patient. So, if type A is donated to somebody who has type A blood, that patient will have type B antibodies. But type B antibodies don't attack type A blood type, so nothing happens. They're fine. On the other hand, if someone with type A blood, if type A blood is donated to somebody who does not have an A blood type, that person, the recipient who does not have that A blood type will make antibodies that attacks the type A blood, and there will be binding and agglutination occurring. So class, concept check. Can a person with type O blood accept A without agglutination occurring? Why or why not? Also, can people with AB accept AB blood type accept more blood types than people with O, A, or B? And then finally, which blood type is able to be used most often as the donor blood type, and why? So this is kind of a meaty concept check question. Go ahead and rewind the video to get me an answer, or you can pause the video and check your textbook or check your notes. 5, 4, 3, 2, 1. All right, let's address the first question here. Can a person with type O blood accept blood type A without agglutination occurring? The answer is no. If somebody has type O blood, they will produce antibodies that attack A and B blood types. So if that type O blood type recipient receives a donation of type A blood, their antibodies will agglutinate the type A blood that's donated into their body. And that's a bad thing. Let's address the second part. Can people with AB blood type accept more blood types than an individual with O, A, or B? And the answer is yes. AB, particularly AB positive, is the universal recipient for blood typing. And they can receive those blood types because they do not make antibodies that attack the A antigen or the B antigen. And then finally, the last question, which blood type is able to be used most often as a donor blood type and why? The correct answer for that is O negative, or the O negative blood type. And that O negative blood type lacks the A antigen, it lacks the B antigen, and it also lacks the rhesus factor, the RH antigen. So there's nothing on the surface of the blood that should be able to trigger an immune response if it's donated to somebody else, and that's why we use O negative blood as the universal donor. Now, I just mentioned RH factors, or the rhesus factors. Let's spend some more time talking about the RH blood groups. That rhesus or RH factor is used to or expressed as calling the blood type positive or negative. If they have the Rh factor antigen on the surface of the blood cells, they are called positive blood types. So A positive has the rhesus factor, A negative does not have the rhesus factor. These Rh antibodies are only capable of developing in somebody after we're exposed to the rhesus factor. So that's a very important thing I want to point out here. A patient with type O blood will have A and B antibodies naturally in their bloodstream, even before they're exposed to the A or B blood types. But a person who has a negative blood type will not have the rhesus factor antibodies in their bloodstream until their immune system is exposed to the rhesus factor. The most common cause, or traditionally the most common source of exposure, was for a positive blood typed baby's blood to mix with a negative blood typed mother's blood during the birthing process. Why is this really important? Why do we care about this rhesus factor? Well, first we care about it for just general blood donations, blood transfusions in general. But we also care about this because if mom and dad reproduce with each other, and mom has a negative blood type and dad has a positive blood type, it's possible that baby can also have a positive blood type. And in this situation, baby's positive blood can get into mom's bloodstream and cause mom to start making rhesus antibodies. Now, generally speaking, this never affects the first child because this mixing process happens during the birthing process. So, hey, the baby's born. Now that the baby is physically separate from mom, mom won't be able to send her antibodies over to attack the baby's bloodstream. But mom has been exposed to that rhesus factor, and now mom's capable of mom's going to potentially be making antibodies that attack the rhesus factor. And maybe sibling number 2 or sibling number 3, some subsequent child that has a positive blood type will have their blood attacked and destroyed by mom's antibodies that can cross through the placenta or cross over the placental barrier. If this occurs, that condition is known as hemolytic disease of the newborn or of the fetus and can lead to mental retardation and death, and was a very, very common cause of stillbirth or of stillborn children and of miscarriage. So here's a diagram explaining what I talked about. Child number 1 sends positive blood types over to mom. Mom, who is a negative blood type, develops antibodies for that. And then a subsequent child, we'll call it child number 2. The next child who has a positive blood type will have antibodies from mom cross the placental barrier and attack the child's blood cells. So how can we prevent hemolytic disease of the newborn? That Rh negative mom is going to be given an injection of Rh antibodies. The brand name for this is Rogam, and this is going to be done to give the mom artificial passive immunity. In other words, we're going to give mom these antibodies that attack the rhesus factor so that she never starts making them on her own. We generally speaking are going to do this during the birthing process. These antibodies will attack the fetal blood cells that are in the mom's bloodstream and neutralize those fetal blood cells before mom's immune system can recognize them and respond to them. And this is going to have to be repeated every time a Rh negative mom has an Rh positive baby. And general healthcare practice is that we play it safe. We just always give Rh negative moms the injection of the rhesus factor antibodies because sometimes, and this is a less than ideal situation, but sometimes mom isn't sure who the father is. Maybe the father is this positive blood typed guy. Maybe the father is this negative blood typed guy. So to save those potentially embarrassing and awkward conversations and always to play it safe for the life of the baby, we give mom the Rogam injection if she has a negative blood type and she is pregnant. So, class, which blood type is considered the universal recipient? Why? Do not forget the Rh factor. And then also, which blood type is the universal donor? Why? And do not forget the Rh factor. I kind of already answered this question for you in the last concept check. But in case you didn't understand, now you should be able to include the Rh factor. So go ahead and rewind the video and get me an answer. Or you can pause it and check your notes or your textbook. 5, 4, 3, 2, 1. Okie dokie, the universal recipient is AB positive. If someone has AB positive blood, they have the A antigen, the B antigen, and the rhesus factor antigen expressed on the surface of their blood cells, and they will not make antibodies that bind to any of those antigens, so they can receive blood from anyone who has any of those antigens. The universal donor is O negative. If you have O negative blood, your blood can be given to anyone because you do not have the rhesus factor, the A antigen, or the B antigen on the surface of your red blood cells. So there's nothing on your red blood cells that should cause an immune response in the blood recipient. Let's move on to homeostasis. And we're going to finish up our chapter here pretty quickly. So how does the cardiovascular system, the blood, the heart, and the blood vessels work together to maintain homeostasis in our body? Well, there's lots and lots of things that we do. If we look, or that it does, our cardiovascular system is going to pump blood throughout the body. And we can use this blood to transport heat, transport nutrients, hormones, to move waste products around through our bodies, to transport cells of the immune system. The cardiovascular system, more than any other system, helps to maintain homeostasis in the body by equalizing the internal environment from one part of the body with the internal environment in another part of our bodies. And that is all we have on our presentation for the chapter. If you have any questions, please feel free to shoot me an email, or stop by my office if you are on campus, or post them in the class discussion board. Happy studies!